Good morning, friends. Welcome to yet another session of Dr. Sahasranam's ECG quiz. I hope you have been benefited by these sessions which I have been presenting so far and are getting all the interpretations correct also. Today, I propose to show you two arrhythmias and one 12-lead ECG. So let us go to the ECG straight away without wasting much time. Now this is the ECG of a 25-year-old girl who was brought to the emergency with a sudden onset of palpitations which occurred about half an hour ago. She was continuing to have the palpitations when she came to the hospital. Now, first question is, what is your diagnosis of this arrhythmia? I think it is pretty simple here. You won't take much time to make a diagnosis here. And then the second question is, what are the various methods you would employ of treating this arrhythmia? Now you can start off. I'll give you about 2 minutes for this. Okay. So friends, here it was mainly a diagnosis. So I'm sure you would have made the diagnosis already. So we will go on to the discussion. So let us get on with the discussion of this ECG. What you see here is a classical narrow QRS tachycardia. Now the RR interval here between the two waves is 9 millimeters. I have measured it already. And so 1500 divided by 9 gives you 166 beats per minute. So this is coming absolutely with a very regular, isn't it? What you call as a clockwork regularity. And that is classical of what type of arrhythmia? It's a supraventricular arrhythmia, and usually it is seen in atrioventricular nodal reentrant tachycardia. Now the second point you note here is, look at lead 2 and AVR. I'll show you. Okay, now look at lead 2 and AVR. You can see a small S wave here in lead 2. These orange arrows show that. And in AVR you can see a small R wave after the QRS. These blue arrows show that. This is actually the P wave which is coming after the QRS complex. That is, you know that in reentrant tachycardia there is a re-entry inside the node, inside the atrioventricular node. And every time there is a re-entry and an impulse goes down into the ventricle, an impulse also goes up into the atrium. That produces a tiny P wave which you are seeing here. So this is the classical atrioventricular reentrant tachycardia, or AVNRT, we call it that way. And these are called the pseudo S wave, and here it is called the pseudo R wave. The reason is, once the patient becomes normal, that is once the arrhythmia is corrected, what happens is these will disappear. If you take ECGs, you will not see these waves. So these are really the P waves which are coming immediately after, almost buried in the QRS complex, but after the QRS complex. And this ECG shows a classical atrioventricular reentrant tachycardia. The second part of the question was, what are the various methods of treating this? There are many methods of treating this. So I have put up another slide for you. We shall see in brief in the next slide what are the methods of treating this. Thank you. So let us discuss the various methods of treating AV-NRT, which we have shown in this slide briefly. I would recommend that you read more about this in a textbook of medicine or cardiology, because here I am showing only just points regarding the management. You have various vagal maneuvers like carotid sinus massage, Valsalva maneuver, the gagging, face immersion in ice water, etc. Gagging, trying to induce vomiting, and face immersion in ice water is what you call as a diving reflex, which is seen in certain aquatic mammals like the seal, etc., where when they dive into the water, suddenly exposure to ice cold water in the sea, it reduces their heart rate, so that when they are underwater, their heart doesn't use much of oxygen. So that is actually a protective phenomenon for those animals. That is also used here as a reflex vagal maneuver to abort this tachycardia. Now, there are medications which you can use. You can give a fast bolus of 6 to 12 milligram of adenosine, a 5 to 10 milligram of verapamil, maybe over a few minutes, diltiazem intravenous 10 milligram, metoprolol 5 to 10 milligram, or esmolol 250 to 500 micrograms per kilogram body weight, all given intravenously. Amiodarone can be given but is not usually employed. Similarly, phenylephrine infusion, this was used previously. We have used it in olden days when we didn't have any of these new medicines. You give an infusion, what happens is phenylephrine suddenly increases the blood pressure. An increase in blood pressure through the baroreceptors will suddenly reduce the heart rate. That is, again, it is a vagal stimulation. Now, direct current synchronized cardioversion is the easy method, but we don't usually employ it in practice. We try all these maneuvers and medications in the cardiac ICU or emergency ward or wherever, and if we fail, we can use direct current cardioversion. But if the patient comes with significant hemodynamic abnormality, like a fall of blood pressure, and patient is almost superose or something like that, you don't wait for anything, you straight away go and give a direct current synchronized cardioversion under, of course, anesthesia with something like midazolam. Of course, you can do a competitive atrial or ventricular pacing at that time. Put a transvenous pacemaker and stimulate the heart, atrium or ventricle, to a rate faster than 166. It will abort the arrhythmia. And then you stop the pacing, heart rate will come back to sinus rhythm. Now, if it is recurrent and very chronic, you can use radiofrequency catheter ablation. And similarly, in recurrent arrhythmias, especially in children and young adults, cryoablation is now preferred because it is available. So we'll go on to the next slide. Now, the next slide is that of a 78-year-old gentleman who came to the emergency with an acute chest pain. This is a very simple slide with a simple diagnosis. So my question is, what is the diagnosis? But at the same time, can you tell me what complications can happen in this patient? Just, this is only for a little theoretical discussion of clinical medicine. So friends, I'm sure that this is not at all a difficult diagnosis. We'll go on to the discussion. This is a simple ECG. There are Q waves, you see ST elevation in 2, 3 at AVF, right? So that indicates what? ST elevation and T inversion, which is indicating of a acute inferior wall myocardial infarction. Now if you look at V1 and V2, you can see a tall R wave with mild ST depression and upright T waves. So this indicates a posterior wall myocardial infarction. If you look carefully in V5, V6 also there is slight elevation of the ST here, which of course indicates an extension to the lateral wall also. So the ECG shows an acute inferior wall along with the posterior wall and a lateral wall myocardial infarction. Now what complications? Just like any myocardial infarction, you can get all the complications of any myocardial infarction like hypotension, tachyarrhythmias, acute pulmonary edema. Inferior wall myocardial infarction can also be accompanied by atrioventricular blocks. Don't forget that, because AV blocks like first degree block, second degree block and third degree blocks can occur when there is an inferior wall myocardial infarction, which of course may become normal very quickly and usually needs only temporary pacing. Very rarely you will require permanent pacing in case of complete heart block, which is induced during an inferior or posterior wall myocardial infarction. So we'll go on to the next slide, which is again an arrhythmia. Now this is the ECG of a patient who came with chest pain to the emergency. Two questions are, what is the arrhythmia and what was possibly the cause of arrhythmia? So I'm sure you have answered this because it's a very simple arrhythmia. Of course, both these belong to the same patient, right? Taken at possibly a little different time. So here, this is lead 2 of the patient. Now, if you look carefully, P waves are seen at regular intervals, right? There they are. You can see P waves here coming at regular intervals, isn't it? At a rate of approximately 60 beats per minute. The QRS complexes are seen to follow the P waves, aren't they? Yes, they are following. But look carefully. This is the PR interval of this beat. This is the PR interval of the next beat, and the third beat is blocked, isn't it? So there is a progressive prolongation of the PR interval followed by a dropped beat. Now look at the other side. This is one cycle. Now here again you have a P followed by a short PR interval, P followed by a longer PR interval, still longer PR interval, and a blocked beat, right? Now if you look at the lower panel, again you see P waves. Now here the PR interval is short or normal, then longer longer, still longer, and then blocked. So this block is highly variable, isn't it? The first one, this cycle, it was 3 p waves to 2 QRS complexes, or 3 to 2 conduction. Then it became a 4 to 3 conduction. Then here it became a 6 to 5 conduction. You remember that formula? It is said n is to n minus 1. That is the formula. What is this? This is a Ecg AV block, and it is called a variable Ecg because the conduction ratio keeps on changing, right? And if you look carefully, you can see T inversions here, and a partial elevation or depression of the ST. It's more of a depression of the ST segment, which shows that this patient has an inferior wall myocardial infarction, which is causing the arrhythmia. I'm sure this was a very simple ECG, Ecg AV block with inferior wall myocardial infarction. Okay. So friends, I hope all of you got all the 3 ECGs correct here, because today I have taken very simple ECGs. Your comments and suggestions may be put in the comment box below, and I will meet you soon with another session on ECG quiz. Till then, bye.